Hi, class. It's Dr. Lindner. Let's talk a little bit about the esophagus. The esophagus is this long, muscular, collapsible tubular organ. It's posterior to the trachea, and it connects the pharynx to the stomach. The pharynx is the throat, right? Throat to the stomach. Here's the esophagus. We could see peristaltic contractions. We see the bolus moving down the esophagus. And then right here is the lower esophageal sphincter. Remember, it's also known as the cardiac sphincter because the apex of the heart hangs out right there. So the esophagus is about 10 inches long. It begins at the inferior part of the laryngopharynx, travels through the thoracic cavity or the mediastinum, where it reaches the top of the stomach. The esophagus is going to pass through an opening in the diaphragm before it travels from the thoracic cavity to the abdominal cavity. The opening in the diaphragm is referred to as the esophageal hiatus. Okay, and the internal surface of the esophagus typically is lined with stratified squamous epithelium, right? We want the esophagus lined with many, many layers of squamous cells. If it was just one cell thick, as soon as food traveled down, it could damage that. So we want to make sure that it's many, many layers of flattened cells. So it's stratified squamous epithelium, which is what we're seeing here, right? Everything from here to about here, that is all stratified squamous epithelium. You want many layers of protection there. The esophagus is going to transport ingested material from the pharynx to the stomach, and it really helps to equalize the temperature ingested from the food. You know, like if you're eating something too cold, then it has time to warm up before it hits the stomach. And if you're eating something too hot, then it gives it time as it's traveling down the esophagus to get into the stomach. So it's kind of like equalizing the temperature. If it's too hot or too cold, you've got time traveling down the long esophagus before it hits the stomach. Now, in my earlier video, when I did an introduction to the GI tract, we talked about GERD, gastroesophageal reflux disease. And in the stomach is composed of acids. You've got hydrochloric acid. It's got a low pH. And you got the chyme inside the stomach. And you have the different muscular layers, the circular layers, the longitudinal layers, the horizontal layers of muscle around the stomach that's contracting to mix the chyme with all the gastric secretions. You want to make sure that the lower esophageal sphincter or the cardiac sphincter is closed. Otherwise, if you have a faulty cardiac valve or lower esophageal sphincter, you're going to get all of the acids from the stomach splashing up into the esophagus, creating this burning sensation or this heartburn. So some of the factors that can influence the muscle tone of the cardiac sphincter or the cardiac valve or the lower esophageal sphincter is going to be stress. When people are under stress, I often think of driving by a local hospital and I'll see some of the workers out there with a cup of coffee in one hand and a cigarette in the other hand, and they're just stressed, right? They're doing both. So stress, smoking, alcohol, caffeine, chocolate, fatty foods, spicy foods, obesity, these are all things that can weaken the tone of that sphincter, creating this splashing up of acidity into the esophagus. And that really could be a bad thing. Obese patients should be advised to obviously try and reduce their weight. All GERD patients should be advised by their physician, and I'm sure they would tell them, don't wear anything too tight, avoid tight clothing, avoid heavy straining and heavy lifting, try and eat more frequently, just consume smaller meals. Patients who have hiatal hernias should be evaluated for a surgical correction of this condition. Many people consume antacids. Sometimes they're called proton pump inhibitors, or they're called H2 blockers. Proton pump inhibitors, the proton, when we look at hydrochloric acid, HCl, it's H plus, Cl minus. The H plus, these are protons. So proton pump inhibitors block the ability to produce these hydrogens to decrease the amount of acid, or they're H2 blockers, okay? That creates a problem because you want normal acidity in the stomach, okay? If you change the acidity, you can't break down protein. So there's a problem with protein digestion. You need an acidic environment for B12 to bind to intrinsic factor IF, and B12 work together. It helps to transfer B12 into another part of the small intestine for its absorption. We need an acidic environment to absorb iron and calcium. Otherwise, there could be, if there's calcium malabsorption, osteoporosis, and if there's iron issues, there's going to be anemia. Part of the function of the acidity is to maintain certain bacteria. If you change the pH, you change the bacteria, and you get a condition called dysbiosis, which is bad bacterial overgrowth. So you want to be very, very careful with long-term use of antacids. Even though they're over the counter, it does not mean they're safe. And I have seen patients that have been on long-term antacids that have had all of these conditions, and it's not fun at all. Not fun at all. The complication of gastroesophageal reflux disease, one of them is Barrett's metaplasia. This is a term, metaplasia is a term that describes the replacement of one cell type by another cell type. In a metaplasia is typically referred to as a pre-cancerous condition. In Barrett's esophagus, the normal tissue that one should have in the esophagus, which is stratified squamous epithelium of the esophagus, is replaced by columnar epithelium. And these columnar epithelium are similar to the ones in the stomach. And patients who exhibit Barrett's esophagus have a higher incidence of developing cancer of the esophagus. So here's the normal lower esophageal sphincter. We see here it's closed. Here it's open, and look what's happening to the lining of the lower esophagus. It is burnt, right? It is red. And now you damage these cells in a Barrett's esophagus. You get this metaplasia where the cells go from stratified to columnar. Cancers of the esophagus, again, accelerated growth of abnormal epithelium. Cancer of the esophagus is usually either squamous cell carcinoma or adenocarcinoma that's related to Barrett's esophagus. Cancer of the esophagus is a pretty rare form of cancer in the US, but there's about 20,000 cases a year, and it's been increasing. When you get an abnormal growth of this epithelium, notice that the lumen size of the esophagus, this is an adenosarcoma, it's now minimal. So this is the space that's left for food to pass through. That's why swallowing and eating is so difficult. So the causes of cancer of the esophagus is smoking, alcohol, these two typically go together, foods high in nitrates and nitrites, right? Deli meat that's prepackaged with all of these preservatives, spicy foods, pickled foods, salt cured foods, fried foods, smoked foods, deficiencies in vitamin A, zinc, and even molybdenum. GERD is another cause of esophagus, right? Chronic gastroesophageal reflux disease and exposure to environmental toxins. Symptoms of GERD, it's difficulty in swallowing. We call that dysphagia. Dysphagia typically begins with dry foods like breads, crackers, and then it progresses to more solid food like meats. And then finally, it advances and even liquids become difficult for them to swallow. They get substernal pain, pain behind the sternum, but they also get pain in the back. This is something that's also seen with colon cancer. They'll get pain in the front, but they also end up with back pain. And typical surgery is a treatment, radiation, and chemo that we've seen for all forms of cancer. When we come back, we'll talk a little bit about the stomach. Even though we've mentioned it already, we'll talk a little bit more about it.